by pushing the button corresponding to the answer that you think is correct. Okay? And Chris is going to help us with this, or not. I think I can do this myself. Right? So here's the first question. This is kind of a little test to get you to learn how to use your clicker. But serious business to many of us. What's your favorite football team? So please take a moment to answer. And you can see up in the corner there, I can't see because my eyesight is gone, the number of responses. So it looks like we've got 59 and climbing. If you're not sure that they've got your answer, you can click it again. And I don't know how many we handed out, but we're up to 63. That's a pretty good number. So we'll see what your responses are. You want to do that? Yeah, that'd be great. Here you go. And so there's a clear majority for the Mechanicsburg Wildcats. Who would have guessed that? My goodness. Now, I will tell you the correct answer for this question is number 1. But everybody is entitled to an answer, so there we go. Now we'll go to our next one. How serious is the opiate heroin problem in your community? And you have a sort of a Likert scale there, from 1 to 5. Up to 65. Yeah, we're good. Let's see the responses. All right, so we're preaching to the choir here, and that's a good thing. When we first started doing these meetings 2.5 years ago, that wasn't the case. There was the notion that this is a problem, but it's Philadelphia or Harrisburg or other more urban areas that are experiencing this problem, that we don't have those sort of problems in Cumberland County or Perry County. God's country up there in Perry County, right? So I'm glad to see that we're beyond that. Let's go to the next question. How does the price of heroin compare to the street price of prescription painkillers? Is heroin more expensive, less expensive, or about the same price, about the same cost? Can somebody with good eyesight tell me when we hit 60? Good? Okay, let's see what your answers are. The majority, a strong majority, say heroin is less expensive. And that is accurate. Actually, I'll look to my law enforcement folks to confirm that. Trent and Dave, can you speak to the street price of heroin?
Sure. So on the West Shore, from my experience with the Drug Task Force, an average price for heroin in a single dose, one bag, would be approximately $10. A person addicted to heroin can use anywhere from a few bags a day to 20 or 30 bags a day, depending on how severe their addiction is. When you compare that to prescription drugs, ballpark range would be about $1 per milligram. So if we were talking about a 10 milligram oxycodone, it would cost approximately $10 for that one pill. Typically, from what I've seen, someone can get high a lot cheaper on heroin compared to prescription pills, which is why we're having this epidemic.
Thank you. Dave, anything to add to that?
Like a lot of things, it's also cheaper in bulk. So if you go buy a bundle, which is 10, 12 bags, maybe up to 15, or a brick, which is a series of bundles, you get it for even cheaper. You get down to $5 to $8 a dose. So To start off with, it's a super cheap high, and then as people start to need more of the drug in order to just feel normal, it becomes more expensive. And there's a huge society cost to it because people need to keep generating that money every day. And we'll talk more about that as the night goes on.
Thank you. Okay, let's move to the next slide. About 40% of heroin users used prescription opiates for non-medical purposes before starting heroin use. Do you think that's a true statement or a false statement? And let's see the responses. The vast majority of you think that's a true statement. And you know, this is a trick question. It is true, but it's worse than that. What the research tells us is that of new heroin users, about 80% have misused prescription opioids before they ever started using heroin. Now, that's not to say that a majority of people who misuse prescription opioids move on to heroin use. That's not the case. It's actually a minority of people who misuse their prescription opioids or somebody else's prescription opioids who graduate to heroin use. But when you look at those people who do move on to heroin use, 4 out of 5 started not with heroin, but with prescription opioids. And so that's why we've been emphasizing that that's a big part of the problem, the oversupply of prescription opioids in our communities. In an 11-year span, from 2000, well, that's more like a 12-year span, I guess. But the drug-related overdoses and death in Cumberland County have increased by what percentage? You have a range in there. Come on, somebody's holding back. You gotta play the game. You gotta play to win, people. You gotta play to win. Okay. Let's see what we got. Kind of spread across the board, with the majority going with number 4, 925%. I think I remember the answer to this, but why don't you show the answer? It's 1,550%. And of course, with numbers, Charlie, I'm going to say what I think the numbers are, and you tell me whether or not it's right. I think in 2004 there were only 4.
2.
Oh, there were only 2. Okay, 2 overdoses, and that, of course, was very tragic for those individuals and their families and friends. But it's been growing enormously, especially in recent years. Can you speak to that?
Yeah, the trend is it's going up, and that's the sad part about it. Last year, we had 66 drug overdose deaths in Cumberland County for the whole year. Last night, we just reached 69, so we got 2 months to go. And if you want to factor in the 2 babies that died as a result of opiate overdoses, the mothers were 9 months pregnant when they overdosed. We delivered the babies at the autopsy, and their fentanyl levels, they were probably dead before mom was. So technically we have 71, I guess.
Thank you. In Cumberland County last year, what percentage of drug overdose deaths were opiate related? Not all people who die of an overdose is it caused by heroin or other opiates. But what percentage do you think it is? And the answers are across the board, with the majority choosing 77%. And please show us the correct answer. It's 65%. Charlie, I think it kind of waffles from year to year, between 65 and 2/3 and 3/4.
Yeah, I think it's up a little bit this year. We have 69 this year. 11 of them I'm waiting toxicology results on, but we have 53 confirmed opiates. So.
What other substances do people overdose on?
Cocaine and Benadryl. I've had 3 so far this year with diphenhydramine, which is Benadryl.
Really? Wow. Thank you. Do we have any more? The increase in overdose deaths in the United States since 1999 has occurred primarily among young adults. True or false? Okay, let's see your answers. Ooh, this is split. The answer is false. Majority of you got it right. This problem isn't restricted to young adults. And in fact, in more recent years, the heroin overdoses have just now caught up nationwide with the overdoses from prescription opioids. When prescription opioids, when you look back just maybe 4 years ago, there were more people dying from prescription opioids than heroin overdoses. And a number of those folks were in an older age group, an age group that I belong to, an age group that has lots of aches and pains and lots of reasons to get prescribed prescription painkillers. And so this is not a problem limited to young people. Charlie, can you comment on that a bit too, from your experience?
Yeah, I track my average age every year. This year so far, the average age of my deceased is 36. Last year, I think it was in the low 40s. Last year, my oldest was 88. My youngest was 18. This year, my oldest is 64 so far. And my youngest is 20. So it runs the gamut.
Thank you. In Pennsylvania, only licensed paramedics and physicians are legally permitted to administer naloxone or Narcan. True or false? I'll bet you get this one. This has been pretty widely publicized. Let's not give them a lot of time for this one. Let's see. 3/4 say false, and the correct answer is false. 3 years ago, the legislature enacted a law that broadened access to naloxone to any first responder, as long as they had training and that there was a memorandum of understanding in place where they would have access to a standing order for naloxone written by a qualified physician. Dwayne Nieves has played a key role in Cumberland County in helping those local police departments that are interested in having their officers trained and equipped with naloxone. And Dwayne, can you talk a little bit about where we are right now? And it's been across a 2-year period.
Yeah, Jack, it started in September of 2015 here, early September, and important to note the funding, that's always a question, is where does this money come from, because it's expensive, especially when you're equipping many police officers across several departments. So the Pennsylvania District Attorneys Association has made available grants, and DA Freed's office has been working with that to fund the entire program for law enforcement. Right now, every municipal police department in Cumberland County is carrying and utilizing naloxone, including Upper Allen Police here and Mechanicsburg Borough Police. In addition, the County Sheriff's Department is also carrying. Oftentimes they are out, particularly in the western end of the county where there aren't municipal police departments. They could be close to a call. and help out there. And most recently, Coroner Hall and his deputies are carrying naloxone for the same purpose. They could be out and about near an emergency and jump in even before EMS gets there.
Thank you very much. There's a branch of medicine that specializes in addictionology, the American Society of Addictionology Medicine, ASAM, and they have published best practice guidelines about 3 years ago, actually. And their recommendation is that if a physician is treating anybody with either an opioid use disorder or a chronic pain problem that requires them to use opioids on an ongoing basis, that physician should write a script for naloxone for that individual and their family, so that they have naloxone in their medicine cabinet at home in case there would be an overdose, either from misusing opioids or from misusing the medication that's been prescribed for their chronic pain issue. I don't know if we have any more questions. Here you go. We have these medication collection boxes, an idea that's been heavily promoted by Dave Freed, our district attorney, and we want to check and see if you know in the West Shore area where there are medication collection boxes located. On this one, you can check all that apply, so you can choose more than one answer. And how did our audience do? The correct answers are 2, 3, and 4, Messiah College, Upper Ashley Police Department, and Hampton Township Police Department. We haven't yet worked out arrangements to have it in pizza shops or ice cream shops. But we're very grateful for the police departments and the colleges that have housed these medication collection boxes. Dave, I think in the first year that these boxes were available, how many do we have? 21, 22? And
Yeah, I think we started with either 20 or 21 and went up to 22 or
22 or 23. We're very excited about it because we've, in compared to some other counties, we've got them in all the county buildings, we have them in all the institutions of higher education, and some have come through the grant program through the Department of Human Services. A few of our other ones come from Pennsylvania American Water, who stepped up to donate. The one at Messiah College is from PA American Water. So per capita, we have the most in the state, and we are 4th in terms of total collection by weight in the Commonwealth.
That's great.
They get incinerated. No, the National Guard, the PA National Guard, working, partnering with the Office of Attorney General, has a method approved by the Department of Environmental Protection and the EPA to incinerate them in a safe manner.
In the first year that these boxes were available in Cumberland County, the full course of them, I believe there were over 4,000 pounds of medication turned in. We don't have the resources to inventory what's turned in, but we know from other collection events that generally somewhere between 25 to 33% of what gets turned in is prescription opioids, simply because of the mass quantities of opioids that are prescribed in our country. And so we feel pretty confident that in that 1 year alone, we took 1,000 pounds of opioids out of Cumberland County. And that's it. Thank you for playing our game. We're going to move on to the panel discussion now. And I'm going to pick on a couple people that we didn't pick on yet. I guess that would be Kristen and Jen. So be prepared. Let's see, I have a few questions for them, but I also would like to invite people from the audience to bark up with your questions. We have a couple microphones, and we will have some staff roaming the audience with these microphones. You can also come up to the podium and ask. If you would prefer not to ask a question, you can write a question down on a note card and pass it on up, and we'll have that question asked. So we have some folks that are going to help us with that. But to get us started, I have a couple primer questions as well for other members of our panel. So let me start with Chris. What the heck is RAISE? First of all.
RAISE stands for Recovery, Advocacy, Service, and Empowerment. And what it is a recovery community organization, which means that everybody that works for the RAISE project is in long-term recovery from drugs and or alcohol, or we have friends or family members who are either in the recovery process or trying to seek recovery. We are not treatment, we are supportive services. What we do is we engage an individual into the recovery process, teach them about recovery capital through many of our various programs. And since I said that, we are individuals in long-term recovery, myself, I'm a woman in long-term recovery. I have not used a drink or a drug since September 2nd, 2005. And I tell you that. Thank you. And I tell you that because, it's not all doom and gloom. There are 23.5 million people in the United States that are in long-term recovery, and hopefully we can talk more about that.
Thanks, Kristen. And I'm going to ask both you and Jen this question. So, and I'm sure it's on the minds of many folks in the audience. What I will say is that it's very rare now that we do a presentation. We've done these town hall meetings, but our agency also does lots of smaller opiate awareness presentations. And and I'll mention right now as a commercial, one of the things that we want you to do is think about how can you individually contribute. One way you can do that is if you're part of a church, a service club, some other organization that you think would benefit from learning more about or talking about the opioid problem, then please give our agency a call and invite us out to do a presentation. But anymore, when I talk to groups like that, it's pretty rare not to have to run into anybody in the audience that can't think of somebody in their family, in their circle of friends, who has been affected by the problem. Either they have somebody that is struggling with an opioid-related addiction right now, in treatment, in and out of treatment, or they have already lost someone to an opiate overdose. And so a question is, how do you effectively intervene? And Jen, I'm going to start with you because part of your job is intervention, helping with lawyers who have substance abuse disorders.
I work for Lawyers Concerned for Lawyers, and what that is a statewide. It's a statewide lawyers assistance program that helps law students, judges, attorneys, and their family members who may have mental health and substance use issues. I came to this position in a kind of roundabout way. I'm actually a physician by training. I also happen to be a woman in long-term recovery from an opioid use disorder myself. I had my own private practice in Mechanicsburg for 7 years and developed a devastating addiction to prescription painkillers. Subsequently lost my medical license and had to close my practice. And I lost my medical license for at least 10 years. But the important thing about that is that someone intervened on me, okay, and I got well. Now, the people that intervened on me were the Attorney General's office, but it worked. That's the thing, is it worked. We try to reach people in any capacity before it gets to that level, before the police have to intervene or before they're in legal trouble. Sometimes it's not until after, like it was for me. This is a disease that tells us we don't have a disease. And until the very day I was arrested in front of my practice, I truly thought I had it under control. And for someone with my amount of education and the amount of work that I had done to get where I was, to truly believe that was unreal. In hindsight, I can't believe it, that I thought that. But again, I realized we can't solve the problem. I can't solve the problem that my mind created with the same sick mind. So I needed help. So part of what we do with the Lawyers Assistance Program and what I do in the community, and many of us do in the community as a whole, is there's a ton ton of people in recovery that are living happy and useful and productive lives. So people call on us all the time to help. You know, I get calls from friends, neighbors, teenagers, you name it. Hey, I have so-and-so who has a friend, and oftentimes it's not a friend, it's them, but we get to it eventually, and the key is to be there as a listener. So what can you do is to be able to listen to people. If you think there's something going on, don't try to diagnose them. Mental illnesses and substance use disorders often can look similar in appearance to the outside world and often can co-occur together. So don't be the diagnostician. Just reach out like you would to anybody that you cared for and tell someone that you care about them and you notice that there's a change in their behavior or something may be going on with them. And just let them know that you're there for them. In my experience, when we go at people saying, you need to change and you need to do this and you're throwing everything away, people are less responsive because basic human nature makes us defensive when people come at us like that. So we find, in my experience, that interventions are, in general, more effective if they're approached with love and consideration instead of kind of that old school, you have to change or else. Now, don't get me wrong, for me, it was a you have to change or else. But eventually I came around to realizing that I really did want to make that change. And another thing, as far as interventions go, is the first time is often not successful. So be persistent, be kind, be loving, be there for that person. Because there's often a very small window, be it small windows of opportunity that open from time to time where that person, and I can speak for myself, kind of gets this moment of clarity where they say, wow, I need to do something. And if you happen to be that person that steps in to give them a hug or reassuring support or some words of wisdom at that moment, you can change a life. You can save a life. All of us can do it. And sometimes it's the littlest things. I've spoken to people in my personal experience years ago who approached me within the last month that said, you said something to me years ago. I have no recollection of speaking to them. I don't know what I said. I don't know where I said it. But to them, it was a seed that was planted. And that's not because I had anything wonderful to say. It was just because I was there and I've been through it. So a little understanding and compassion goes a long way.
Jen, you mentioned a lot of times the first attempt doesn't work. Kristen, I know you do a lot of training on the nature of addiction and addiction as a brain disease. Can you talk a little bit about relapse? What is that?
Sure. I think it's important to really understand, what addiction is in order to talk about relapse. And what addiction is a disease. It is not only a disease, it's the #1 lifestyle disease that there is. Okay? And a lot of times people believe that addiction is a moral failure, especially because it starts with a choice. However, it's a disease, it's identified through NIDA, which is National Institute on Drug Abuse, as a legitimate brain disease. And it's also, there's a genetic factor to it. So if you have someone in your family that has the disease of addiction, and it doesn't necessarily have to be addicted to drugs or alcohol, but you consider alcohol to be a drug, they could be addicted to sex, gambling, shopping, you name it. The genetic passage from one person to another in the family, there's about 80 different genetic markers. Okay, so right off the bat, if you have it in your family, you have this 50% chance of having a genetic predisposition to become an addict. Okay, then you have to couple that with putting a drug in your body. Okay, so it's almost like playing Russian roulette, and addiction can take many forms. Okay, it can take obesity, it can take whatever. But anyway, so once you have that disease of addiction, and let me kind of put it this way for you, because I know that jumping from alcoholism to heroin addiction may seem huge, and like how could someone possibly put a needle in their arm? But what I'd like to ask audiences is, think about the first time you ever drank alcohol. Okay, for most of you over 21, maybe not. Maybe you were 19, 18. Why'd you do it that first day? Okay, that's the only question you have to ask yourself. And when I look back to my own, the first use I had, it was curiosity. I wanted to fit in. Adolescents and other individuals today, their drug of choice, the most easily accessible drugs of choice are not alcohol and marijuana today. It is opiates, opioids, heroin, and any other type of drug. So once people start using that, the brain becomes fundamentally changed. Then it becomes a lifestyle disease. A lifestyle disease just like heart disease, okay? So if I have heart disease and I go to the doctor says, hey, you have heart disease, you have to change your lifestyle. You have to stop, smoking, you have to stop eating fatty foods, you have to exercise, and you have to take medication. Most likely I might fight it a little bit, but I would eventually heed the doctor's advice and make those changes to my lifestyle. It's the same thing for the disease of addiction, where if I'm diagnosed with the disease of addiction, I have to make a lifestyle change, which means it's so much more than simply putting down the drug, okay? I have to change my people, places, and things, my coping skills, and basically everything about my life, okay? And that's really hard to do for an individual because the disease component, and Jen talked a little bit about it, there's also this spiritual component to it called denial, where we say, I don't have that disease, that's not me. So a lot of people that enter into recovery or try to get recovery the first, second, third time, what happens is that they go in and they try to do it their way, okay? They say, I'm gonna take this piece from it, I'm gonna take this piece from it. I'm not gonna do that, because that seems like too much work. And I'm just gonna stop using the drugs. Well, the drugs are just a symptom of the disease of addiction, okay? It's all of the other behaviors that come along. So unless individuals enter into the recovery process and completely surrender and say, okay, I'm gonna do everything I'm told. Because I have to remember this, when I'm working with individuals that are new in the recovery process, I say, listen, your way got you here, okay? Your way got you a bed in rehab. Your way got you a bed in jail. Your way got you, revived with Narcan. Your way doesn't work right now. And in that beginning, we have to completely abandon all of our thoughts and let other people help us make decisions. Then there's a human element to that where, our ego gets in the way and everything else, and we think that we can manage this by ourselves. And I'll tell you what, no one can manage the disease of addiction by themselves. It takes a community, it takes a support group, and it takes a family. And all of these individuals have to be educated on what the disease of addiction is.
Thanks, Kristen. Okay, I want to switch gears here a little bit, and let's come back to Upper Island Township, the Mechanicsburg area. And Trent, how common is opiate abuse, heroin abuse in this area?
It's to the point now that it's out of control, which is obviously why we're here. I can remember when I first got hired as a police officer 10 years ago, we didn't hear about anyone in the township using heroin. Once or twice it would pop up and it was almost just unbelievable. But now it's to the point where the overdoses, seems like they're weekly, sometimes 2 a week. And just our DUIs have increased because of drug DUIs. So now we have DUIs occurring in the middle of the day because of people using drugs instead of at 2 in the morning because of alcohol, like it typically was for years. So it's snowballed from the time I started just 10 years ago until now. It keeps snowballing out of control because of all these different factors we're talking about.
Do you see it in other criminal activity as well?
It does. It has a ripple effect because the addiction is so expensive, that person has to come up with money somehow. So that leads to the property crimes, the robberies, the burglaries, the retail thefts. So then it increases all of the workload of our police department because of all the other crimes that occur because of an addiction.
Dave, can you add to the discussion too in terms of countywide? The accessibility, the availability, the price of heroin now compared to, say, 10 years ago?
Sure, and I think Trent has seen this, he's had the front row seat to this. I have to thank Upper Island Township. Thank you for having us, by the way, and the Women's Club for organizing this, but the township officials in particular. When we cried out for help, that we needed more help, more boots on the ground in law enforcement, they gave us a full-time officer to do drug work. They were the first municipality in the county to do it. Other municipalities have followed suit, and so I want to thank them personally for that. My first overdose death was in 1998, and it was one of my first cases in Cumberland County, and it was incredibly unusual. Fast forward again to right around when Trent started, there was a little pocket of some people using heroin in Mechanicsburg, but a couple went to rehab. I think somebody died, somebody went to jail, and it went away. Fast forward about another 6 or 7 years, and I just had occasion to go back through a lot of old paperwork of mine, and I found some testimony that I delivered along with District Attorney Marsico from Dauphin County in the legislature in early 2013. So we were over in the legislature talking about heroin and opioids in early 2013. I've learned so much in the past 5 years or so much from a lot of the people sitting up here, including Kristen and Jen. Jen, what a story, who has every right to have just given up, and she didn't, so we're proud of her. What has happened in the last few years is that heroin has gone from the drug that these groups would band together and make trips to Philadelphia to purchase and come back and share, to the dealers, what I call the for-profit dealers, moving here to sell the drugs. That used to be crack cocaine, not to the level that we have heroin by any means, but we had the dealers coming in from Philadelphia and New York to sell crack cocaine, particularly in Carlisle and around Carlisle. That has changed. There's a little bit of crack coming back actually lately, but when the for-profit dealers showed up and set up shop, that's when we really knew we were in the throes of a crisis. Add to that we are the fastest growing county by population in the Commonwealth of Pennsylvania. By the end of this year, by the end of 2017, in a very simple measure, and that is adult criminal cases in Cumberland County, we're going to be 1,000 cases over where we were in 2015. 1,000 cases. The largest growth in cases, I'm in my 12th year as DA, the largest growth in cases we had before last year's increase of 620 was about 40. We're going to be 1,000 in 2 years. And this epidemic is contributing substantially to that. It's easily available because the demand is out there, the supply is up. This is a public health crisis, and it's a criminal justice crisis. We have extra boots on the ground. We're buying a lot of drugs. When we get the for-profit dealers, we're sending them to state prison. We've done more drug delivery resulting in death cases than any district attorney's office in the Commonwealth. Now, I don't want to get too far afield, but those are the cases where you prosecute the person who sold the drugs and hold them responsible for the person who died. And I know there's some debate surrounding those cases. One of the things that we try very hard to do, just like we do with drug delivery cases or possession with intent to deliver, we try to separate the people who are dealing to support a habit or using with friends or delivering to a friend and using together. We try to separate them from the dealers making money off the deal. Those are the people that we've sent to jail for drug delivery resulting in death, people who've made money off of that sale and off that death. And those are the people that we try to lock up in state prison for the dealing. People who truly have a substance use disorder, we're all about treatment. And I've become even more about treatment as I've spent more time with people like Jen and Kristen over time. We're not out of this yet by any means. The numbers are still going up. There's some research out there that says it won't peak until 2020. I don't know how legitimate that is. So on the criminal justice end, we're doing criminal justice things. We have an enhanced drug task force, and we're getting after it. On the public health end, some of the stuff that we've talked about, medication collection boxes, getting naloxone into the hands of the police officers. We have a Good Samaritan law in Pennsylvania, which provides some protections for people to call and get help for people who've overdosed. That gets into a really difficult issue, though, because when we save a lot of these people, they don't get charged with any crime. But we also don't have any way to force them into treatment. Now, forcing people into treatment doesn't work. I've learned that. You have to be ready. But man, is that tough when we send somebody back out there on the street to use again and potentially overdose. That I think right now, to me, beyond all the law enforcement stuff, beyond everything we're dealing with, that is the toughest issue that we're dealing with. It's what do we do with the persistent substance use disorder person? How do we get that person into effective treatment? Prison is not effective treatment. We need to get them into effective treatment, which has to be long-term and sustained in order to work.
Yeah, and I will say that's one of the top challenges facing our agency as well. As an agency responsible for public-funded treatment, is to put in place with the 3 hospitals based in Cumberland County an effective warm handoff system for those people who show up in the emergency room having survived an opiate overdose. We're working with potential providers right now to put something in place. But another challenge with that is that naloxone is very, very effective, and maybe we can move next to talking more about naloxone as a lifesaver. But in saving somebody's life, it blocks the effect of the heroin or the other opiates. It also puts the individual into full-blown withdrawal in a very quick fashion. And so they leave the emergency room in a state of high-level withdrawal, and intense drug-seeking behavior kicks in. And so part of our discussion with the hospitals is going to be, is there some way that we can address that aspect of the problem as well?
Can I say one more thing, Jack? I don't want to dominate, and I probably won't say much after this because I want these people to talk, but one of the things that we've learned, and you're here, so you're interested, and maybe you're all plugged in and you know this, but I think Kristen talked about choice. I think when we're talking about people with substance use disorder and opioid addiction or heroin addiction, there's very little choice involved. Maybe after the initial experimentation, there's almost no choice. This is needed not to be sick, and the reason that people overdose and die is because they're trying to chase that feeling again and they can't get to it. It's nearly impossible to get to it, and it just stops being all about choice. So don't ever think of somebody, look, if you do crime, I'm going to have to deal with that. And if you're a danger to the public, I'm going to have to deal with that. But I understand fully that sticking a needle in your arm is almost never by choice. And I think it's really important for everybody to remember as we talk about this.
Talking about naloxone, I'm going to turn to you, Dwayne. Can you talk a little bit about, since we have the police departments engaged in Cumberland County, how many officers are we talking about? How many occasions, saves have there been? What's the success rate when naloxone is deployed?
Absolutely. Over 200 officers are equipped with naloxone, and I failed to mention earlier, because they're new, they came on at the same time Charlie and his deputies did. Messiah College Security is also carrying naloxone, effective just a couple of weeks ago. So well over 200 officers equipped with it. They've used it since the beginning of the program in September of 2015, 179 times. And I forget the exact reversal number, but it's 86% today. So one thing we're seeing that's, I guess, is to be expected as the law enforcement use increases, the EMS is plateauing or even dropping off a little bit month to month here and there, because the law enforcement officers are on the street. Sometimes they're a couple blocks away. EMS may be coming from their station or from another emergency. So the law enforcement being more concentrated in communities are getting there.
But it is important to note that all of that police activity is in addition to EMS activity.
Absolutely, sure.
And I shudder to think where we would be if we didn't have our EMS and police officers there on the scene administering naloxone, what our fatality rate would be.
Jack, can I just add one thing about naloxone?
Sure.
I think it's important to also put out there that, sometimes you're the first avenue of defense against this disease and someone who's overdosing in front of you. So our physician general, I believe it was 2 years ago, delivered a standing order for the whole state, which means you don't need a prescription to go get Narcan from a pharmacy. It's covered by most insurances. I believe it's for a pack of 2, it's $75. In addition to insurance coverage, so for some people there's no copay at all. But it's important that everybody knows that, because if you have a loved one who's battling this disease, whether it's with pills or heroin, it doesn't matter. or you have a loved one who is in chronic pain and is taking escalating doses of opioids because of chronic pain, even as they're taking it as directed by the physician, I think it's imperative at this point, now that we know better, to do better. And so get that prescription, keep it on you, keep it in your house, keep it in your car. The odds are, one of these days, you're going to save a life. And we wish we didn't have those odds, but that's how prevalent this is becoming. So while the police and EMS are angels, sometimes you're the first responder. So be that first responder and be able to save a life. You can do it just by walking into the pharmacy.
The prevalence of this problem has made many of us first responders. There's problems in library restrooms. There's problems in fast food restrooms, fast food restaurant restrooms. And so, yeah, there's a need for lots of folks. And I believe at the table in the back, we have copies of Dr. Levine's standing order for naloxone. So if there's anybody here this evening that would like to have a copy of that in your hand, see Kelly Kiefer at the end of the back of the room. And this is also a good time to thank all of the provider agencies and the Mechanicsburg School District who have set up resource tables around this room to be able to advertise the helping resources, the prevention, intervention and treatment resources, and recovery support resources that are available in the community. Because we don't want you to walk away from this meeting tonight without being aware that there is a lot out there that can help address this problem. But getting back to naloxone, one of the challenges that I remember hearing is that we're having to use more naloxone to successfully save somebody's life. Can you explain that, Wayne?
Yeah, like you've already heard, with addiction and dependency becomes a need for a higher concentration of the drug, a higher dose of heroin or whatever the prescription opiate may be. So we find ourselves giving more naloxone just to get the desired effect. First of all, a lot of people, I spend a lot of time debunking this myth. Naloxone is not new. It's been around since the 60s. It's been available from paramedics in this county since the early 80s when paramedic service came to be. So we've been using it all along. What is new is the widespread availability, certainly. But yeah, we are finding a lot more repeat doses than we ever saw. There was probably 12 years ago, hardly anybody ever got more than one dose. And an opiate overdose is easy to spot. Pinpoint pupils, poor respiratory effort. It's very, very simple to spot. Police officers with minimal training, EMS practitioners now at all levels, not just paramedics, but EMTs, firefighters can be involved in the program. So it takes very little training to spot that. And we are seeing many, many repeat doses necessary just to get a response.
Now I want to turn to Charlie because I suspect that part of that is that that we're not just doing with heroin alone anymore.
No, nearly, I'd say 95% of my toxicology results are showing fentanyl. These drug dealers, believe it or not, they're business people. So they figure if I can cut my cost, I can make more money. So they start cutting the heroin with fentanyl and God only knows what. They're cutting it with cocaine now, so we're seeing that in a lot of toxicology. And fentanyl is very powerful, and it doesn't take much to kill you. So if they cut it quite a bit with fentanyl, and these addicts think they're shooting up heroin, and it's a lot of it's fentanyl, and they're doomed. They're done. And that's what we're seeing a lot. We have not had any carfentanyl in Cumberland County yet, but it's been in Franklin County, Dauphin County, York County, so it's been around us, and we've just been fortunate enough we haven't come across any yet.
What is carfentanyl?
Carfentanyl is an elephant tranquilizer that veterinarians use, and you know why anybody would shoot up with an elephant tranquilizer is beyond me, but most of the times they don't know it, and the next thing you know, they're dead. And you know, and you talk about Narcan and naloxone, and thank God we have it, because my numbers would be well over 100 this year already with the saves we have in Cumberland County by EMS and law enforcement. But we're getting more and more drug overdose deaths that have been saved repeatedly with Narcan. My one girl that I talked about earlier that was 9 months pregnant, she was saved 5 times before she overdosed, including 24 hours before she overdosed. So that's the addiction work. They can't help themselves. They gotta have that high, and they try to do it whatever way they can do it. And that's why the numbers are going up. And just to go back a little bit to our little pre-test there we had, the one question was, how bad do you think the epidemic is? And I noticed that 6% said it doesn't impact me. Well, it does. It impacts each and every one of us in this room, because the more my numbers go up, the more money I have to spend of your tax-paying dollars for toxicology, autopsies, and whatever to determine what happened to that person. So it does affect you. It affects your pocketbook.
A big debate at the county level right now is our prison is busting at the seams. And we have the capacity out there to open another housing unit, but that would be a very expensive proposition. And so we're trying to figure out ways to forestall that, delay that. But what's driving the population are the number of opioid-related crimes that are being committed.
Just to add to Charlie's earlier number about his number of overdose deaths this year has already surpassed last year. Just to bring that sort of around full circle for you, with the naloxone administration, EMS and police in July, late July, we passed 2016 numbers of naloxone administration agents. So everything since late July has been above and beyond what was last year.
So Jack brought up what we're dealing with at the prison. You know, we could just open the wing and pay more corrections officers and fill up those beds. One of the things that, and I use this in the last couple of years as a talking point, we have county prisons are run by prison boards. So the prison board's a district attorney, a judge, county controller, sheriff, county commissioners. So we have a monthly prison board meeting, and one of the measures that we see is our detox numbers, right? That's people who are arrested coming in who need to be detoxed. And as time has gone on, our detox numbers have gone like this. From it would be alcohol here, drugs, particularly opiates here, it's gone like this, right? So we're doing a ton of opiate detox. And the reason I bring it up is that's just one part of what needs to happen. And this is where, Kristen, you take over and talk about why simply doing detox doesn't hit the root of the problem.
Sure, yeah, that's what I wanted to talk about, so thank you.
Not our first rodeo.
No, I've done this before. And I just want to make it clear that all this talk about Narcan, it is not a lifesaver. All it does is restore breathing. Okay, it doesn't cure anybody, it doesn't do anything. And I want to talk to you about why people go back to Narcan and tie it into detox. What happens to somebody when they start using anything, basically any substance, over a prolonged period of time, is what happens is that very first time someone uses, what it does is it increases dopamine. And it's your own dopamine in your brain. Okay, the drugs don't have dopamine in them. So what it does is it forces all your dopamine out like a rush in your brain. And it feels so great. And there's studies done that say that people with a substance use disorder have fewer dopamine receptors to begin with. Okay, it doesn't mean they're walking around manic depressive. They're just always trying to seek dopamine stimulant activities to increase things in their brain. So anyways, you use the drug, it increases massive amounts of dopamine. So you use the drug over and over and over again. You're flooding your brain with your own dopamine over and over and over again until there's very little dopamine left in your brain. Okay? So if you would give a brain scan to somebody that is in an active addiction or in detox, you may find that there are very, very extremely low levels of dopamine. Now, it takes about a year to 18 months for that dopamine to get back to where it was before someone ever put a drug in their body. Okay? So that first year to 18 months is so imperative. When we bring someone in for detox and simply release them because of insurance funding or whatever, they're going back out on the street basically with no ability to feel good on life's terms. Okay, and that's where all the recovery process comes in and life skills come in and where we surround the individual. Now, let me tell you what happens when we add opiates to the mix. Okay, because opiate addiction is a whole nother monster that you can tackle. Is that not only do they have to deal with the lack of dopamine in their brain, but now every time someone uses an opiate that's not intended for severe pain, okay, what happens is it attaches to new receptors in your brain. And your brain says, I like this so much, I'm gonna create more receptors. Once a receptor is created in your brain, it must be filled with an opiate. If it's not filled with an opiate, you go into what we call withdrawal, okay? Now, withdrawal is like having the flu, but you're gonna times that by about 100, okay? That is no lie, that's exactly what withdrawal feels like, okay? The individual that's going through withdrawal, and Dave already talked about this, you know, basically the drug takes you, because now you have to know that if you're that sick, all you have to do is go back out and use one time, and all those symptoms are gonna go away. And that's where people get in this very, very vicious cycle of opiate addiction. When someone is revived by Narcan, what happens is that they go into day 3 of withdrawal immediately. Okay, so they're sicker than they've ever been before in their life, right? You're meeting them on their worst day of their life. Okay, they've essentially died. Not many people that are reversed with Narcan are gonna wake up and say thank you, okay? Because they are so sick. The flight or fight comes in and they just want to get out. Now, historically, we've taken people to the hospital and we have been unable to give them services, right? That same person with a lifestyle disease, let's say that same person coming with a heart attack would go right to the ICU and get life-saving services. This person that has overdosed has come to the hospital being released with a pamphlet saying, you should probably make an appointment for drug and alcohol counseling, right? We are very fortunate here in the state of Pennsylvania that we're trying to change that through our ward handoff for overdose survivor programs. A lot of our counties are up and running. Cumberland County will eventually, right, be up and running at some point. There's a lot of other factors that are involved in that, okay? So the reason why I'm saying all this about Narcan is because I have seen the comments on articles. I had a friend who was reversed 30 times. Yes, 30 times, okay? He was reversed 30 times. He is now living, he is now thriving, he is now working in the recovery community, going to college, got all of his fines, he's getting married. He is a pillar in our community. And he said, thank God somebody had a vision for my life, because I didn't. He was so sick. And you know, he's gonna work for the rest of his life paying it forward, and he's done a great, phenomenal job. But if you would have read this article, the comment said, let him die. Why didn't we let him die? You know, that's a human being. And I think the thing is that we have to remember that these people, myself included, we have a disease, okay? That can be treated, but you have to be able to basically surrender and take the treatment that's offered.
Thank you. I'm going to switch gears now and see if we have questions from the audience. Yes?
I read the article about your friend and the 30 overdoses. And not being a drug addict is hard to understand. And I have to admit that the thought went through my head too. Why would the expense, but isn't there a better solution? I mean, 30 times on Narcan? And I'm sure there's probably people out there that 30 times it still didn't work and they keep, and the number gets higher.
If it was your daughter, your granddaughter, or someone you loved, how many times would you give them Narcan? That's what I say to people who say, let them die.
No, I didn't say let them die.
No, I'm not saying you said, I'm not in any way insinuating that you said that. I apologize. What I'm saying is that is something that crosses my mind or other people's minds. I couldn't understand addiction until it was me, until I was an addict. You know, I had the same thoughts as everybody else in the community who's not an addict until it happened to me. But if it was my daughter, my grandmother, my loved one, I would give them that Narcan just as if they had a peanut allergy and for some reason they were just obsessed with eating peanuts. I'm not gonna cut them off after giving them epinephrine 10 times. You know what I mean? Like, if we approach this as the disease that it is and we keep the human element there, what would you do if it was your loved one? And that's the way I approach it with people who come, and I understand the thinking. Why do we bother? That's why we bother, because there's a seed that's planted every time it happens.
Okay, but you also said that the Narcan makes you feel like the worst case of flu.
Yes.
Isn't there something that they can?
So, and I think maybe Dwayne can talk about this a little bit. I'm sure I know what he's going to say. There's a new school of thought on how to revive people to get them to the emergency room, which is not give them, first of all, as bystanders, if I had Narcan in my home, I wouldn't try this. Dwayne can do this, you talk about it. Yes.
This is where we part a little bit in EMS and medicine. We give just enough to restore breathing. In other words, not to wake them up, make them sick, and all those things. A little more difficult when you're talking fire, police, other public safety that don't have all the training, all the educational background to do that. We very much titrate it to effect so that we don't bring them back to that point. And also, it's more hazardous. You know, if you take them to that point and we've just ruined a high that they've spent money on, oftentimes they're not very happy with us. So that's sort of that part of that. Is that what you were asking?
Yeah, and I also want to go back to my friend who was revived 30 times. He was revived in an era where there were no services for him. So it's basically, I'm on the street, I'm helping a person with a brain disease. I'm taking them out of whatever acute situation they are, but not giving them any help. And this gentleman, he didn't get any help over and over and over again. Partly because we just weren't set up like that in our counties. And I think we're very fortunate that now we are turning the tide where we're saying, hey, if we bring this person to the hospital and we don't give them services, of course they're going to be back here. You know, we're not giving them the resources they need. And we can talk about resources. There's so many resources available. There's places here tonight with the resources. There is help available for almost anybody that needs it. It's just knowing where to get it. You know, and I'm going to put a shout out because right now it's like if you're in Cumberland County, call the commission. They will direct you if you have insurance, you don't have insurance, or whatever. Call the RACE Project, call Gadenzia. But there are services for anybody that needs it. This guy didn't have those services.
Kristen, one of the things that I've heard you preach is that there are many paths to recovery. What does that mean?
Well, there's not a one-stop shop for recovery, basically. You know, there's short-term pathways, which would be rehab, detox, a halfway house, outpatient counseling, you know, inpatient counseling, all those. Those are short-term pathways, but we need to find a pathway, and there's medication-assisted treatment as well. But the RACE Project, we like to call it medication-assisted recovery. But there's also long-term pathways that someone must find. And that could be a mutual support group such as Alcoholics Anonymous, Narcotics Anonymous, Smart Recovery, Celebrate Recovery, church, holistic. There are so many pathways. You know, I'm looking straight down the aisle and see Steve. There's even recovery centers here in Cumberland County where people can just stop by. His recovery center is at the old Triple R Guitar right in Lemoyne, right? This is a center where people can just stop by and be engaged in the recovery process, being around other people all day long. These are resources we didn't have 10 years ago or 5 years
Just
ago.
for today, wave your hand in the back.
Yes. Yeah, there's so many resources, and I think that the stigma came from the fact that individuals weren't recovering on their own because we weren't giving them the resources that they needed. And unfortunately, the addiction epidemic didn't really get any attention until unfortunately we started losing individuals to the opiate crisis. And now it's making its ugly head, and it's been here for a while.
Speaking of resources, and before we run out of time, I want to make sure that we do a commercial for the Mechanicsburg Area School District as well. And Paul, I wonder if I could call upon you to point out briefly the drug education and the student assistance intervention programming that is available through the school district. Sure. If Chris can give you a mic there.
Thank you. The student assistance program is available in our secondary programs required by law. We have a student assistance program, but in our district we also have an elementary program because the problems with mental health and drug and alcohol are sent into our elementary grades. The student assistance program is a volunteer program. It is something that a student can be referred by a parent, by another student, by a teacher, anybody who knows them. There are 2 tiers in the student assistance program. It could either be for mental health, drug or alcohol, or a student could be referred to for both. We partner with Teen Line for the mental health and Cumberland Perry Drug and Alcohol for the drug and alcohol. And counselors come in and do assessments on students. And again, it's voluntary. And students have the ability and parents have the ability to say thank you, take recommendations and go outside and get additional help, or continue to follow through with the recommendations made by the mental health or drug and alcohol counselors. I started with the elementary program, and this is something that I think that we need to look at as a society. Is we're required to have a secondary program, but not required to have an elementary program. And everybody knows that early intervention is the best tool and the best source of prevention. And we pay for our mental health and drug and alcohol screenings at the elementary out of our general fund because we believe that much that early intervention is the key. So anybody who has connections who can advocate for expansion of the student assistance program to not just include 6 through 12 grades, but to include K through 12, would be much appreciated.
Thank you. Can you also share with the mic with Gina behind you, because Gina is here in a couple of roles tonight, Drug-Free Pennsylvania, but also part of a parent group in the Mechanicsburg area.
Sure, thank you, Jack. First of all, thanks everyone for being here tonight, because this is the first step, and this is definitely a community issue. About 3 years ago, a group of parents here in Mechanicsburg approached the Mechanicsburg School District, and we jointly began to create an educational program for parents in the community. Over the course of the last 3 years, I would say we put on about 7 different sessions of education, and we are currently in the planning process right now for this up and coming year. November 2nd, we are meeting at the school district at 5:30. If you would like to join us, we are looking at sessions again for this year. Some of the topics that we're looking at is marijuana in teens, just kind of also a general overview of just substance use disorder, taking a look at perhaps barriers and some things that we can assist the parents with. And then the third is something called Screenagers, which is basically a video that highlights the damage basically that the use of the children using screens, whether it be computers, phones, whatever, the damage basically that it causes, specifically depression, and how does that correlate directly to potential substance use disorder. So I do encourage you to please join us again on November 2nd. We're looking at topics, and at this point I do believe we're going to probably hold the sessions here. So thank you.
Thank you very much. Yes, sir.
Yeah, this is just rewinding a little bit on the Narcan, and it was mentioned that there's really no, I guess, penalty or legally anybody that they can be held accountable for. And I mean, I know that there's really no answers. There's a lot of open or not things that you're not going to be able to do anything about. But it seems to me that if somebody's is saved by the Narcan, I mean, just like if you get a DUI, you're held accountable. It's almost like there's no accountability, and I wonder if it's somehow promoting like irresponsible drug use, or that if somebody's on addicted, they feel like they can just, and nobody wants to overdose. I know that, but why can't you got to go for a DUI, you got to go to classes. I mean, these people that are getting saved by the Narcan, it's almost like you're not trying to penalize them. You're actually even helping them by saying, hey, you were saved. This is what you got to go through now. You're going to lose your license, and I just wonder if there's anything like that, to
There
force
are
them
some
into
things
help.
under consideration. Dave, maybe you can talk about.
Sure. Let me tell you where we were and where we are and where we're going. So this the Good Samaritan statute in Pennsylvania was passed as one of the reactions to this crisis. And the idea of the Good Samaritan statute was this: we've all been confronted with situations where a 911 call would have saved somebody's life, and that call isn't made. I'm thinking of one, I can't remember if you were involved in it, the trend in Mechanicsburg, where the police were actually driving by a residence and saw 2 people carrying a body out. A young lady that could have been saved if 911 had just been called. But people didn't call because they didn't want to get arrested, they didn't want to be responsible. So the idea originally was this: if you call and identify yourself and stay, and you have done something illegal, you, the person who calls and stays and gives information, will be immune from prosecution. Not the person who overdosed, and not anybody else, the person who calls and stays. And if there's two people and they call and stay, sure. Well, what this has turned into through court interpretation is person who ODs can't be prosecuted. If you do it in the bathroom at the library, or the McDonald's in Somerdale, or the Sheets out here in Upper Allen Township, and some bystander comes in and calls, you're still immune. That's not what the statute was intended to do. Now, minor drug possession, low-grade misdemeanor, probably going to get probation, but there's a probation officer involved. And there's somebody that might be able to put a hook into you to make sure that you're doing what you're supposed to do. Does that solve all the problems? I don't know, because it's hard to force people into treatment. So Jack talked about warm handoff. That's an idea of bringing people in and at least trying to help them avail themselves of services at the time. I went and testified on a bill in the legislature last year, and I was very disillusioned after coming out of there, because Dr. Levine, who wrote the standing order, and I am a huge fan of Dr. Levine. I mean, Jen's a physician, so she can tell you, that's a big deal that the Physician General of this Commonwealth took the initiative to write that and have it out there. I mean, that's amazing, and I'm proud that I live in a Commonwealth where that was done. But what I heard at that hearing, just addressing this very issue, what do we do with that person who's saved, is that, oh my God, it's hard, and it's expensive, and there's not enough beds. And you know what, those are all excuses, right? Out there on the streets, Trent's out there and Dwayne's out there picking up bodies. And we've got to be able to address this. So the warm handoff thing, I think it's trying to be done. We're trying to address, some people have tried to address it pre-arrest. We won't arrest you, but we'll take you and at least get you evaluated. I'm willing to do that on low-level drug arrest if we get to that in Cumberland County, understanding what's going on. But it is, you probably tell from my voice, the most frustrating thing that we're dealing with, because I think what had the best of intentions and still works and saves lives has been misused and has probably cost us lives as well.
If I can just add one thing real quick about treatment options. In November, Pennsylvania went live with 1-800-622 doctor. Of course you would never mix medications. You'd be insane to do so. I did it myself a decade ago, and I would do it every day if I needed to not be sick. And we talk about chasing the high or that sort of thing. I can speak from my own experience and the experience of people that I know in recovery. After a very short period of time, you're not chasing any high. There is no high and there is no feeling good. It's just not being sick. It's being able to get out of bed and maybe get to work. That's what it comes down to. I am not, at the end of my time, even like 3 months into it, I was not looking to get high, feel great. No, it was I need to get out of bed at some point today, and I can't because I'm shaking so badly. So it helps, I think, give a little bit of perspective to the disease if you hear things like that. Yes, it is not a choice, it does not absolve us of responsibility for our actions. Those are compatible for it not to be a choice and to still be responsible for our actions. So I want to make that clear. No one's insinuating that addicts, because it's a disease, should get off scot-free whatever behavior we decide to do. That's not at all the case. But back to the mixing of medications, of course we don't do it. As physicians, as normal people in the community, we would not think of mixing medications. But when you're in an active addiction, it happens, and it increases the risk of overdose exponentially.
Folks, we have time for maybe one or two more questions before we close. Ma'am. Do we have a mic here?
Yeah.
Thank you. Thank you, Sally.
6 months ago, I lost my adult daughter to a drug overdose in Cumberland County. She's on the list. In that 6 months, three of my closest friends have lost an adult child or grandchild to almost identical conditions. All of these kids grew up in nice homes. They went to high school, they played sports. Well, the point I'm getting to here is that I was told her death was manslaughter, And we gave them, found so much evidence and information. And her friends came forward and said, I think you should give this to the police. I did. I've been back to Hampton Township numerous times because as a parent, I need some closure. And I'm always told the same thing. The detective that's working on your daughter's case is not in the office today. I'll give him your phone number and he'll give you a call. And I hear nothing. I truly understand what you're saying now. I didn't understand the magnitude of the problem and how overworked you are and how horrendous it is and impossible. But I want to be there at the hearing or whatever that I'm permitted to be part of, just because I want to see that person's face. I want to know who those businessmen are, or those people are that started it, and who was that person that sold my daughter the drugs that killed her. How does that happen? What do I do? Do I have any?
Let's talk when we're finished, and I'll get your info and we'll get you an answer.
Okay.
Time for one more question.
Do many people that are addicted really want to be helped? I mean, I know this Narcan's got to be devastating in the budgets for one thing. And if they want to be helped, how can you tell if they do or not? I mean, I know there's not enough treatment room for everyone.
I'll handle the budget question real quick. We're working on getting reimbursed from a grant, and the grants generally come from the insurance companies. However, all the Narcan that's been purchased in Cumberland County has been funded by the drug dealers we took the money from in the first place. So, and I'm happy to spend it in that manner. But that's not hitting taxpayer dollars. Now, the governor just put out $5 million for us for naloxone, which I think is great because we're saving lives. I'd like to see that commitment to treatment beds too. But on the question of like wanting to be helped, I think we have to let the recovery folks jump into that.
We'll both answer this one, right? Okay. So, I didn't grow up saying I wanted to be an addict. Never did that come through never, ever. I didn't think I would. We talked about early education today, and that is so important. There wasn't a lot of messaging all throughout my life. Not that it was just wasn't there. So no, do we want to be helped? We live in fear, okay? Fear is part of our disease. Fear of the fear of staying stuck in active addiction because we know what's going to come is a lot easier than the fear of getting clean and having to deal with life on life's terms and what will it be like. I was externally motivated to go to treatment, and I went to treatment at 5 different places. It was my mother, who's actually here tonight, who, for the last time externally motivated me, and I still wasn't ready. Got into treatment, and something while I was there changed inside of me. Everybody needs that chance, okay? I don't know anybody that I know, and I've got a lot of friends in recovery, not one of them said, when I grow up, or when I get older, I'm gonna become a drug addict. Go ahead.
I can speak to, when is there some sort of telltale sign that someone's ready to get help, and unfortunately the answer is no. But I can tell you that based on my experience personally and with people I know in recovery, oftentimes it takes getting the drug out of your system long enough to have a clear thought. And I know that may sound simple, but like I said, I sit up here as a well-trained physician and I thought I had it under control until the day I was sitting in the back of the police car. That's absolute insanity. So the disease, it's not an excuse, it's just a fact. It kind of kept me from realizing that I needed help, let alone did I want help. The few times that it would occur to me, the overwhelming fear of the stigma and losing everything I had and worked so hard for my whole life kept me from doing anything except the very same thing, which got me to almost losing anything anyway. But I will tell you that getting someone into detox and getting them into treatment, it wasn't until I could have what I realize now was a clear thought. I wasn't having clear thoughts for a long time, but I had a rational thought. And under rational circumstances, surrounded by people that want to help, of course I want to help. So I think it's getting the drug out of people's systems long enough to make that decision, and that's very, very difficult. But you don't have to wait that long either. For sometimes it's when people are really, really sick. We call it dope sick or whatever it may be, when you're miserable and you don't have what you need to stay well, that's also when we can kind of get people into treatment, because they're willing to do pretty much anything to not feel the way they're feeling at that moment, which is what got us into the problem in the first place. We can use that as an impetus to treatment and healing.
Folks, thank you very, very much for coming out this evening. We're going to respect the time frame. We've agreed to go from 7 to 8:30. We're a little bit over. The panel members will remain here to talk to people individually for a while after. Please also take advantage of the resource tables that are available from our treatment providers, the recovery support provider, and the mechanic